All right. Well, Bri, welcome. Welcome to the peer-to-peer series. I'm so pleased you asked to be a part of this.
Absolutely. I'm
Yeah.
happy to share the good word of Walt Fritz at any
The
given
good
opportunity.
word, the good word. Good. Hey, introduce yourself if you will.
Absolutely. My name is Bri Worek, and I am a speech language pathologist and vocal coach here in Nashville, Tennessee. I have been an SLP for the last 15 years and have gradually over time been transitioning into singing coaching and using my SLP expertise into that realm as well. And so have lived in Nashville, Tennessee for the last year and a half, where my client caseload has really transformed into working more with adult singer-songwriters and people possibly who are musicians but still recovering from neurological conditions, whether it be traumatic brain injury, stroke, things of that nature, voice disorders, of course.
Yeah, yeah.
Mm.
So this question is just like totally off the wall. How do people view a speech pathologist being a voice coach versus somebody trained in a vocal pedagogy experience type of thing? Do you have any feedback on that?
Yeah, and I think that my perspective on that is I think it depends on what lane you're trying to go into and the language that we're using.
Hmm.
So, if we are talking about strictly singing, that to me is a little bit different than when I have someone who happens to be a singer, but they're having a voice issue, or they were a musician and now they've had a stroke. So, I think that there are certainly a lot of really educated vocal pedagogy, vocal coach folks out there. Have I come across some that are maybe making claims that are a little bit out of their lane to do like voice therapy, for example? I think there's always that slight
Hmm.
turf war of sorts as far as what we're doing. And there's times even for me, I feel musically inadequate because my degrees are not in music. So I've had clients where we're really just strictly doing singing coaching. And even for me, I'm sure that there's vocal pedagogy people that are like, well, you're a therapist. I feel like that works both ways.
Yeah.
And it just depends on what you're trying to do. I'm always very clear with guidelines on either end of the spectrum about what I do specialize in and what I don't. And opera is not one of them. So
Hmm.
I'm very transparent
Yeah,
about the
yeah.
things I will and won't do. So,
That's great. That's a great description of maybe some of the differences. I know the turf wars are out there no matter what.
oh, for sure.
Yeah, kind of encounter them a little bit sometimes when, I start dipping my toe into your world and people say, "Wait, you're a PT. Why are you doing that?" It's like I'm not trying to replace you. I'm trying to, augment you. And yeah, but anyway, I think turf wars are just part of defending our own turf, right? Profession, right?
Absolutely.
Um, peer to peer, we're here to help the newcomer to manual therapy when it comes to the coursework taught, and also people who are maybe thinking of dipping their toes into it. You started in a slightly different manner than a lot of the people who take my class. A lot of the people who take my class, their first encounter is taking the in-person class. You took my online class first.
I did. So when I moved to Nashville about a year and a half ago, I wanted to make a recommitment to myself for continuing education. And I had a boss in the skilled nursing facility I worked at in North Carolina who had taken your coursework, Debbie Porter.
Mhm.
And she had told me for years, man, you've got to check out Walt's courses. He's big in voice and manual therapy. And I feel like for a lot of speech therapists, even though that totally isn't our realm of appropriate practice for hands-on laryngeal work, it's so out of our comfort zone because we don't tend to be hands-on practitioners. And so when I finally had the opportunity to spend the time on your courses, I did start with the online coursework, going through your website and saw that you offered so many things. And I believe I did the three pack bundle where it
Oh,
was
the
like voice
bundle,
and
yeah,
swallowing with advanced
yeah.
and whatnot. Because I said, well, let's just do all of it for sure. And so I felt like you had a lot of great detail with all of the examples that you provided. But also for me personally, I did feel like it absolutely gave me enough to start working with it. But I followed that up with just a couple months ago meeting you in person at the end of June 2026 is the year we're in. And taking that in-person course felt like a fantastic supplementation. And even though it was a review of what you included in the videos, I think being able to have that partner exchange and you provide that live feedback just grew my confidence even more with using the techniques, even though I'd been using them straight from the online course. I did feel comfortable enough to do that because the work that you encourage is so gentle in its way.
Hmm.
I never really concerned myself that, oh my gosh, am I going to do harm to someone? Because your online course is detailed enough in itself for the
Yeah.
information you provide.
Yeah. So, Bri, did you find it awkward, difficult, sort of like going out of that, like that comfort zone when you started
Mhm.
using this work?
No, I think like anything else I do. So if I use music as an example, I think that we want to think that touch is universal. We want to think that music is universal. If I have a client or a patient specifically where music is not their bag, I'm not using music as a modality to target speech, language, cognition. That's just not something I'm going to use. If they're really sensitive to touch and it's something that they don't like, I'm not going to use that either, right? I feel like any of the modalities that we might use, no matter what it is, you have to find that thing that that person connects with because there's other patients I have that I've used the hands-on manual therapy techniques that think it is the best intervention they had for their dysphagia, the best intervention they had for their muscle tension dysphonia. And others, we start doing work and they say, I don't know if that really did anything to me. And you
Hmm.
say that very honestly in your videos. It's up to the patient to guide what their sensation is, what their comfort level is, and what they're feeling. It's not up to us, it's up to the
Right.
patient.
Right, right. Which is a big switch. And, I know sometimes, a lot of times in my practice here, I get patients who are literally ready to be passive, ready to be, willing to do whatever I think is best, willing to, I can take it, right? Do whatever
Right.
you need to do to fix this. And for a lot of my patients, I know it's a big learning curve, and it's part of my, responsibility and duty to let them know that it doesn't have to hurt to help. It's
Hmm.
optional. Some people actually, I do believe it has to be aggressive, not necessarily for their tissue, but their values and expectations, right? I think I
Hmm.
need to be flexible enough to meet them at a place that they feel, okay, you're doing something now. And, I do struggle sometimes with patients who are totally unaware that they can have a place in this, that they can have a voice in it, no pun intended there, that
Hmm.
literally they help me help them. And some people, they're kind of put off by it. Have you encountered that at all?
Um, Not as much in my personal experience. I feel like the clientele I've seen so far are usually pretty comfortable with telling me what's what, but I think also
Hmm.
some of that might be the expectation of going to a PT versus a speech therapist because
Yeah.
there's still a lot of people when we say, "Oh, I'm your speech therapist." Well, why are we working on swallowing? The connections aren't always as automatic, but when you're going to someone, and again, this is just my potential theory and opinion, and I know that physicality is involved. I'm expecting to be physical with a physical therapist.
Hmm.
Maybe that expectation is a little bit higher with the bar of physically what they expect pain wise.
Yeah.
It
Yeah.
shouldn't be painful, like you're saying, but
Yeah, no, fair enough, because I know that there are therapists who find that, well, it could be rehab staff where they're working. It's like, well, why are you doing that hands-on work when that's
right,
traditionally the role of the physical therapist, for instance?
right,
But when you're out there on your own, you don't have to worry about a supervisor sort of looking over your shoulder and saying, do you have documentation for that? Do you have evidence for that? Even though I feel we do have a good evidence base for this work,
right.
right? Yeah, yeah.
Yeah.
So then it doesn't sound like you found it that difficult to begin incorporating it. Is that pretty accurate?
Yeah, I think like anything else, I'll ask a patient or client what they've tried in the past. Sometimes I have people that have had a long-standing issue for quite some time. If I'm in the hospital, it is more of an acute situation, of course. So sometimes
Hmm.
it feels like the therapy team and I were throwing spaghetti at the wall to see what sticks.
Yeah,
And
yeah.
I don't want to say special, but somewhat special in the way that when I'm in the inpatient rehab, hospital setting, I'm there Friday to Monday. So I feel like I'm the aunt of all of the patients that then turn them over to mom come the weekday therapists that are kind of their team leaders. But a
Yeah.
lot of times, the other therapists who are not trained in manual therapy, they'll say, we've been doing this type of dysphagia intervention, we've been doing this, we've been doing that, but you're the one person that does the manual therapy. Can you give this a shot? Because we've done everything else, and we know that you might be the linchpin that's going to really get things going. That does happen
Yeah.
quite a bit. And they do like
Yeah.
to use the word somewhat colorfully of the black magic,
Hmm.
because if you're not trained in it, it just seems like, well, what are you doing? What are your hands doing? What's happening? Until you get this patient feedback of, I feel like that's the most effective thing that I've done so far. That
Yeah.
has happened multiple times.
Yeah. I mean, the contextual value of touch cannot be understated, not as a universal, right? But for a
Right.
lot of people. I know this might be very different in your past and present, but I can tell you that, well, my practice is it's a manual therapy practice that I strongly include exercise and movement.
Hmm.
Because without those pieces, you know, gains don't tend to stick around. You need to get that movement piece back in. And whether movement is, lifting weights or kind of singing with a sense of I don't have as much pain, that sort of
Hmm.
movement. But I totally forgot where I was going because I went off on that sidebar. And I won't even bother editing this out. Let's just move on and I'll
Yep.
pretend that, yeah, that was all part of it. What about advice? What about advice for somebody? Because I think that is a common thing that I hear is, I was a little cautious about applying it. I really didn't want to feel like I wanted to apply it until I got good at it, right? Which I
Hmm.
really try and reinforce in the classes that it's like you're going to get good by working with an actual person who can give you actual feedback on their actual condition.
Hmm.
What about you?
Yeah, and again, like anything else we do, speech therapists, I feel like are that very special type A breed. And
Mhm.
like any other skill, I think we want to wait to be good at it, to start it. And
Yeah.
unfortunately, part of becoming good at anything is trial and error and fumbling and,
Yeah.
cracking a few eggs to make the omelet. I mean, you're
Yeah.
you're gonna do something that someone goes, "Whoa, what was that?" Or, "Oh, ah," so that's always par for the course, no matter what we do as therapists. Like I said previously, sometimes I think music is the most universal thing that anyone can enjoy. But then I do my weekly music group at the hospital, and you get that occasional person that comes, kind of looks like this, is 20 minutes in, and is like, "Can we go now?" And could
Mhm.
absolutely care less, right? So it's just trial and error and practice, and you just have to
Yeah.
jump in.
Yeah. I know that when I started this work, kind of taking the continuing ed classes back in the early 1990s, I was just about ready to transition out of early intervention in the home care. So, I kind of incorporated a beginning in the earlier intervention. I had a mentor there who had kind of kicked my butt to take that first class. But then when I went into home care, you're out there on your own. It's the Wild West. And
Hmm.
I noticed that, I was getting a lot of patients who I file and I can't get up. They broke their hip. We were doing the normal PT, transfer training, all those, safety things, but they also had a lot of secondary comorbidities of pain and other things that now this is back in the early 90s when insurances were a lot more lenient. And it was like, okay, I've got this other skill set that I'm learning. How about if we try some of this? And I tell you, they were like very eager and grateful recipients of that because, someone was spending time with them in a setting where people typically don't spend a lot of time. And that gave me the confidence to say, okay, let's try using this more. Open a small private practice in your living room, that sort of thing. And I mean, that's
Hmm.
literally how I got my start. But I know that sometimes you just sort of thrust back into that busy setting of a hospital or wherever you're working. And it's like,
Hmm.
wow, how am I going to fit this in? And I do think that is one of the things that I hear a lot. I didn't quite know how to really get the courage to actually try it.
That's a really good statement. And I do both. So the room I'm sitting in now, this is my office in my home where I see my private clients, and they do tend to be singers mostly that I'm seeing in this particular setting. But also the people that I work with patient wise in more acute care, inpatient rehab in the hospital, I do find that relationship building and rapport is important. If I'm in acute care and I have 8 minutes that I'm seeing someone, that's not
Yeah.
exactly the most ideal time to do these techniques, because even just to explain what you're going to do and making sure that that person feels comfortable with you is important. And I'm not saying it's impossible to do in acute care, but my personal experience has been the clients that I'm seeing in my home that I know that I have an hour with, because at this point, I don't see anyone for less than an hour in the private capacity because I just don't feel like, reasonably speaking, I can get enough done. And
Yeah.
that's just my personal experience. If I'm
Yeah.
in the inpatient rehab, well, I do have 30 minutes. I could possibly do a full hour with them on my schedule. So I do have more time. But also, those people are being seen by us for about 2 weeks. So you do build a relationship and you do have a little bit more time and the length of stay that they're there as well. So that has been my experience, that the more rapport you have, the more time, the more beneficial these techniques are to implement.
Yeah, I think it's really interesting that, the really separate hats that you wear, that whole vocal performance and rehab, as well as the
Mhm.
acute care. And I know that from people who are sort of like testing me out, well, is this class appropriate for, and then fill in the blank of a setting. I think acute care is the one where people probably have the more thought that, well, that manual, you wouldn't be doing much manual therapy during that acute care setting, but you
Mm.
found ways to incorporate it, correct?
I've not had as much, but again, I feel like I do so many things that my time is so divided between
Hmm.
acute care and inpatient rehab. If I was strictly in acute care, because we do have therapists in our hospital that are, and they might see that person 5 days a week, right?
Yeah.
And they're on a specific unit, and that's kind of their unit that they cover, and they really do build the relationships. It's just for me personally, I float so much between patients just based on my Friday to Monday weekend schedule versus if I was one of the
Right.
Monday to Friday therapists in acute care and they are seeing someone multiple times in the week, they do build that relationship. It is absolutely possible.
Yeah.
Absolutely possible. That's just not been what my experience has been.
Yeah. Great. Great. What about advice? Picture yourself, you're acting. What, I do these videos to put you in the role of a mentor in a way.
Mm.
Advice for somebody maybe who's considering taking it, or somebody who's taken it and it just doesn't quite have the roadmap on how to start it. Any specific tips or advice that you have? And I know I'm kind of throwing things out of the blue at you. So yeah.
I think the advice that I would give is that you just need to start with a conversation with your patient. I think that's the best thing that you can do. Explaining what the techniques are, what their comfort levels are, which you talk about all the time in your coursework. I mean, you talk about that very explicitly, Wald. And I think that is the best number one step to take, because if you explain it and they say, no, I don't think I like that, well, then we're not going
Mhm.
to do it. If you
Yeah.
explain it and they say, okay, let's give it a try, and you just start dancing. It's kind of a dance of sorts. Does this feel
Mhm.
familiar? Does this feel helpful? I think that's the best way to start, because the person is going to tell you. And
Mhm.
if someone expresses to you, oh, that right there, that feels extremely helpful. Well, how do you not provide the help to the person that just told you what's helping them?
Yeah.
That's our job. That's what we're supposed to do.
Yeah. Yeah. At being in private practice now for 26 years, you build a website, the website's constantly evolving, you get a new website. But the one thing that I learned early on was I want to make sure that when someone's coming to see me, they have a real clear picture of who I am, what I look like, because those are important. They really are, I think we do check people out that way, right? In terms of safety, in terms of appropriateness, but also in terms of the setting, right? My setting here, but the setting that I use with my hands-on work. So like right at the top of my private practice website, I have a video right there. And whether people watch it or not, that's up to them. But then they can sort of get a flavor for who I am.
Hmm.
And is that appropriate? Because there are some people who are looking for a PT, who's in a big gym with all kind of exercise equipment. And when people walk in here completely unawares, they kind of look around. It's like, where's everything? It's like, well, this is it, right?
Hmm.
And I know if you're working for a hospital or something like that, it's more difficult to do. But that's always a suggestion to me to say, as a speech pathologist, here are some of the things we can be doing, right? And it's like you sprinkle all of them in, and you sprinkle it in there so people at least have been warned, if you will, right, that you may touch. When the last speech pathologist they saw never touch them, all right?
Hmm.
And maybe you're sort of ruining future speech pathologist engagement with the person you're working with because they're
That's
going to say,
happened.
"Hey, how come you're not using manual therapy like Bri did?" Right?
Yeah.
But I do believe in giving my patients as much advance warning, information and
Yeah.
education as possible.
Oh, 100%. And I had a clinical fellow at our hospital text me just yesterday because there's a particular patient who one of his biggest goals was getting back to his music. So, oh, that was right up my alley. I spent the whole weekend with him. I've never really made an aphasia binder, but I made you a perfect music binder. That worked great for
Mhm.
me. And we're working on memory, we're working on dysarthria. And she texted me yesterday and said, "Oh, I have him tomorrow for therapy. I'm not a musician. What am I supposed to do?" So regardless of context, that can happen all the time.
Right,
And
right.
it's that continual dance of what is the patient into? What am I into? What can I use of myself as an extension that they're going to connect with, that's going to help them the most? And I'm sure you've gotten this too, Walt, where you're doing something and totally unrelated to the topic at hand. The person just starts emotion dumping on you about past
Mhm.
experiences, and they go into, I don't even know why I'm saying this. And I think things like that happen because you're able to provide comfort for people
Mhm.
and
Mhm.
safety.
Yeah,
And that's one of the biggest gifts we can give our patients is
yeah,
feeling comfortable
yeah.
in the space that they're in with you.
That acknowledgement of past events, of emotions and things like that.
Yes.
In my background, that was always sort of gifted to, well, we store our emotions in the fascia, and when you release the fascia, the emotions come out. And even when I was learning that back then, I knew it wasn't really accurate, but I didn't have a
Right.
better story. I really didn't have a better story, but there's a lot of really good evidence out there. I quote a study in the seminar by McParlin that talks about those properties that contextually appropriate affective touch have on eliciting a memory of a prior. That's what
Mm,
McParlin called a prior, a past experience. And, to me, there's nothing voodoo about it. It's providing that safe setting, right? As in a safe environment, et cetera. And you're using some of the physiology of touch, the neurophysiology of touch on what that can foster. And over the trajectory of my career, I was a fascist for decades, where everything was about, well, that's what fascia people are called. They're called fascists, Brie. You got to get this clear, okay? And I know in the context of our country right now, that might not be well taken, but
ouch.
when I was a fascist, thinking everything was fascia, right? Everything got explained by that. But the more I learned, the more I realized there's so many ways that touch can impact a person swallowing, voice, airway, whatever, as well as that emotional regulation, those sorts of things. And that's what I like to do, is not narrow in on that single story of, oh, we're breaking up muscle tension here in the larynx, right? Well, we are, but how that happens is really nuanced and complex. I do get cynics saying, well, if it works, why do I care? Why do I care what it is? Because, I think it's important to look at all the stories, well, which is impossible, more stories than your inherited one, right? Because if there's aspects of behavior, of psychology, of other things that are in there, the more you know about it, the more you might be able to handle it better and, work with them in the next setting as well. So anyway, I do believe strongly in evidence-based practice. I do believe strongly in not just looking at the evidence of speech pathology or physical therapy, but behavioral sciences, et cetera, because there's
Yeah.
so much to be had. And I learn more from there, literally sometimes on the meta that surrounds this therapy than I did from my early history in physical therapy and myofascial release.
Absolutely. And so many of the singers that I work with, it's not even that they necessarily have a singing problem all of the time, and especially in a place like Nashville, I work with clientele who they're already professional singers. They're
Mhm.
already performing. They're already getting paid to do this. But they have moments of muscle tension, right? And then when we start unlocking what's behind their voice, whether it's through manual therapy or we're just talking about things. And again, clear lines. I'm always clear to
Hmm.
say, I'm not your psychotherapist. So there's
Hmm.
a time and place for that too. But just allowing people to get that emotional piece off. If someone starts spilling their guts to me and I just go, yeah, 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 but we're not here to talk about that. Let's go back to the scales, and I just keep playing my piano. I mean, that's kind of monstrous, right? How do you not
It is.
give them space to unpack that? And one of my very first clients I had in Nashville that I started doing the manual work with, and I had bought my massage table. I, got what's the hand stuff?
The
Ball,
liquid chalk.
liquid chalk, yes, because you're a
Yeah.
chocoholic. I got my liquid chalk. I had my gauze. I had all of the things. I was ready to go. My gloves, and I had them on the table, and we were doing some tongue release things. And we finished, and he goes, I don't really, well, maybe that was something. I don't really know. And he texts me not 24 hours later with one of those texts that's just the entire length of your phone. And to the extent of, I feel like I've been holding back on things emotionally my whole
Hmm.
life. And even in relationships with my partners and da 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 da. And I said, well, that's not really what I was going for. But if you felt like that released something, okay, great. And
Yeah.
sometimes it's not immediate. I get messages from people days later. I see them the next week and they say, yeah, no, that actually was something. And now when I'm singing, I'm not perceiving that tension or I'm connecting in a different way with my breath, whatever it may be.
Yeah.
So it's not
Yeah.
always immediate, too. And I think we want to provide that immediate result, and that's not always immediate, and that's okay too.
Yeah, yeah. By the way, for those of you who are watching this video, don't be confused. You don't have to work on a massage table. We actually teach
No.
a lot of it in sitting as well. I don't want to
Yeah.
misrepresent here. I actually did used to do all the classes from a laying down position, but that's transitioned a lot. And how did you find working in sitting versus laying down as a therapist, and maybe even as the patient when you were a lab? Did you like that
No, yeah.
contrast?
I really, really did. I feel like in the hospital, laying down can be tricky because usually the gym is hogged up by the PTs and the OTs and they're on the mats and everything like that. So from the angle of the hospital bed, that's not always the most convenient, but I've
Mhm.
definitely done it when they're sitting in their wheelchair, and I usually carry my own personal iPad around with me, so I'll switch it to the camera settings so we can have a mirror, they can see what I'm doing while we're doing it. We make the
Yeah.
modifications where needed. In my office, I have honestly probably done more from a seated position
Hmm.
than laying down. And I don't know if that's just because with singing, it feels a little bit more natural to be upright. But
Yeah.
sometimes we're just playing with different postures, and I'll have people laying because you just never know where someone is going to connect. And you have to sometimes put them in awkward positions. I feel like, especially with singers, they need something that is atypical from what they're used to doing to get a different sensation if they're used to being on stage, standing upright, playing with their guitar. Well, if they're just that way all the time, they're not necessarily going to get a new sensation until we're maybe sitting down, lying on the back. Or are we, I mean, Pink is famous for her vocal exercises where she's doing full handstands the whole time with
Mm.
her legs up against a wall and she's flying through the air. You never know what someone is going to connect with. So you kind of try a little bit of everything.
Yeah, yeah, that's a really interesting perspective because I tend to lean into, well, put him in the position of contextual relevance, right?
Hmm.
Sitting, standing, whatever. But kind of mixing it up a little bit could be a really interesting way to go about it too. I mean, I've worked with patients with voice, et cetera, issues standing up where I mean, I'm short. I have to stand on a stool to get my hands in these areas, but yet
Hmm.
there's something about being in that position in space that really triggers that, not just the feeling here, but the memory of the feeling here. And that's really what I strive for. But I like what you just said, just sort of shake it up sometimes.
Oh, I'm always shaking it up. Some people are very visual, so then maybe
Yeah.
I use a pitch monitor or a decimeter. I have an auditory feedback device that's this headset so that they can hear themselves with the bone conduction added. I feel like I am a magician, just like pulling things out of a hat sometimes to find the
Hmm.
one thing that's going to
Hmm.
connect with somebody. So.
Well, you're using the black magic of the manual therapy,
I'm
so that just
using the
fits right in. I get in my office, I get a lot of patients calling it voodoo. It's like, yeah,
voodoo.
if you want to call it that, but I don't really like to wear that hat too much, right? No, it's just another way of coming about things, right? But I
Maybe
do
it's all
think,
the skeletons. Maybe you need to go down on the skeleton use.
yeah, because I got one right out in the other room too. Yeah, yeah, yeah. So anyway, is there anything else you want to add, or because this has been just a brilliant sharing of your world too. I really appreciate it.
Absolutely. I think my favorite thing, not to, make your head too large, Walter. I want you to be able to fit through the door when you walk out today.
Thank you. Thank you.
But
Yep.
I feel like truly what you provide to the very type A and somewhat nervous speech therapy community is a sense of empowerment. I've told you that before. You provide a truly collaborative learning space and an empowering space that you were one of the first people that I heard say, sometimes we don't always know the answer, or sometimes
Mhm.
it doesn't work and that's okay, and sometimes we can't explain it and that's okay. That was so freeing and mind-blowing for me to hear, because we put such a high expectation as therapists to figure it out, to find the
Mhm.
exact best thing, and to hear that there's other people out there that are sometimes throwing spaghetti against the wall, and
Mhm.
does it work, does it not, do we have the explanation? Sometimes, not always, and maybe that's okay, and we don't have to.
Yeah. Yeah. I have learned though that typically if I say just I don't know, it's like that's
Yeah,
not
it doesn't
enough.
sell well.
Often I have to follow it up, and I'm fond of when someone asks me something, I'll say, I'm not certain. Then what I'll do is I'll pick out what they came in with, because typically people come in with something. My
Hmm.
doctor, Dr. Google, my friend, whatever, right? Some
Right.
organic kind of theory that it must be my posture or it must be something, right? And what I'll try to do is say, you know what, I'm not sure. It could be your posture, like your doctor said. It could also be sort of a neurologic remnant your brain hasn't let go of yet. So give them the idea that, okay, I'm not dumb. I know
Right.
possibilities, but I'm not locked into one, right? And I think that's important because when I was transitioning to this model, I used to just stop at, I don't know. And you could see the faces go like, whoa, am I paying this
Mm,
guy how much for this? And he doesn't know. And I think, I don't know, but works better, right? Add that but, add a couple plausible but different,
yeah.
disparate explanations. Lets them see, okay, there are a little out of possibilities. I know I talked about in the class that there's research out there that says typically we're not changing their beliefs, even though we try and educate them on pain science, we try and educate them on these things, but chances are they're going to walk out of my door thinking the same thing they came in with. I just want to instill on them that, yeah, you could be totally right what you said, but there could be other possibilities too. And some of those other possibilities sometimes bring hope that your story didn't bring, you know? So,
Oh, absolutely. And there's a voice instructor here that I very much love the material she shares. And she talks about vocal registers as an example as being a bit of a snake pit. And vocal register is that, okay, is it chest? Is it head? Are we saying it's falsetto? Is it this? Is it that? And voice in and of itself is just such a complex thing. How can you
mhm,
say that it's just one thing? How is it absolutely the vocal cords are doing this versus this muscle versus this? I feel like leaving it open-ended is truly the right approach. And I feel
yeah,
like like you said, the I don't know, well, that's kind of a wall, and that's making us stop right there. But when we're saying, okay, well, it could be this, it could be that, I'm always struck by people that I see on the internet that say, well, this thing, whatever we're talking about, is 100% that.
yeah,
I the confidence and audacity that you think it's that straightforward with the human body is incredible to me.
yeah.
I almost wish I had that brazen confidence sometimes.
Yeah, yeah. That's a whole nother interview that will
Right?
be.
We're
Yeah,
done now. We'll
we're
stop.
done. Yeah, yeah, yeah. Anyway, we're done now, Bree. I do
Perfect.
appreciate you taking this time out of your day to share your story.
Absolutely. Thank you,
All
Walt.
right. You're welcome. Thank you.